It is well recognised that blindness is more common in the poorest countries of the world. Yet, even within these regions it can vary, with more remote rural areas suffering the greatest burden of blindness. This is because those living in more isolated areas are busy farming the land, have the least money to pay for treatment, and the greatest challenges travelling to health centres. This is all the more difficult in the rainy season, when roads turn to rivers and travelling becomes perilous. Malawi is also one of the least urbanised countries in the world, with over 80% of the population living in remote, rural areas. Many people consequently fail to access glasses and cataract surgery, or be screened for blinding diseases such as glaucoma or diabetes. By improving knowledge and skills of eye disease amongst community-based carers, such as health surveillance assistants, as well as equipping them with diagnostic tools, awareness of eye disease can be improved and treatable disease identified earlier, preventing needless blindness. As part of a wider eye care strengthening programme in 10 targeted districts of the central eastern region of Malawi, a community-level primary eye care training programme targeting HSAs has been established. This is a collaboration between CBM UK, Nkoma Eye Hospital, Manepo, the Ministry of Health and the ArcLight project team of the University of St Andrews. The initiative has been funded by UK aid to improve knowledge, skills and access to diagnostic tools amongst 1,300 HSAs, offering care to over 7 million people. After an initial 2-day training the trainers course, local Malawian ophthalmic clinical officers and optometrists led primary eye care workshops for HSAs in rural locations throughout the entire Central East region. The course materials are based on the World Health Organization's Primary Eye Care Training Manual for Africa. Participants were additionally equipped with Wilson devices. These are low-cost, solar-powered diagnostic tools developed by the ArcLight project to deliver effective primary eye care by community-level healthcare workers. A bright LED is powered by a surface-mounted solar panel operated by a single button. 2 powers of lenses allow the front of the eye to be examined in detail. At the other end are pinholes for visual acuity testing, and if needed, a speculum can be added to also examine the ears. At the start of a course, participants receive a Wilson device as well as training materials. The programme manager gives an overview of the whole initiative and introduces the lead local trainer, either an ophthalmic clinical officer or optometrist, who has previously attended the Training the Trainers course. Participants in the different sessions are then taken step by step through history taking for vision loss, anatomy of the eye, visual acuity testing, assessment of the pupil, and examination of the front of the eye using the Wilson device. History taking emphasises the different causes of vision loss, both gradual and sudden, as well as distant and near. This leads into visual acuity testing using the distance, illiterate E and near testing types, pinholes on the Wilson, and a 1 metre tape provided to each HSA. Time is taken to measure the testing distances accurately and demonstrate the correct technique, with participants using their new tools and practicing with each other. Examination of the pupil is taught in stages. Initially, the observable features of a normal and abnormal pupil are described. Then the technique of assessing response to light is demonstrated, with participants examining each other. Finally, a mobile phone-based app is used to train, then assess technique and interpretation of normal and abnormal pupil responses. Examination of the front of the eye is then described using the Wilson device. Participants examine each other, then systematically study and discuss clinical cases illustrated on their course cards. All the materials, including instructional videos and posters, are also available to download onto participants' phones. At the end, time is given for questions and discussion regarding the course and how and when to refer on cases. Coming together for training has other benefits beyond just improving eye care. HSAs typically work alone and only occasionally enjoy teaching sessions together. The opportunity to meet their local eye care lead, as well as each other, sometimes for the first time, share experiences and learn from each other, can improve communication and collaborative working, strengthening healthcare delivery in the region.